Thank you, Shobhi. Thank you, Ghosh. The first, let me tell you that the sponsors of this session is the makers of Glycomet GP and Urava Trio and Trio 4. So, the theme of that division of USB is Go Green. And that is why everything you will see in this slides will be all in green. So, as Shobhi has given the lead, this green swan is actually solutions that make us exponentially forward towards a breakthrough. Now, it's not that this metformin and sulfonylurea are taking us to this breakthrough new. It's a tried and tested molecule, it's a tried and tested combination, and over the years, it has served mankind to a great extent. So, in this era of all the new OADs and IHs coming in, like the DPP4 inhibitors from 2009 to 2010, SGLT2is from 2013 onwards, the GLP1 RS from 2010 onwards. It is, where does this combination stand? Why are we still talking about metformin and sulfonylureas, the modern sulfonylureas, I must say? We know that there is a robust experience. There was a time when this was the things which were only prescribed by the doctors. There is an incredible speed of decreasing HbA1c. There has been the guiding light in terms of continuing this therapy globally across the populations, across the population range as well. So it has been trusted over the years because of the massive experience. So sulfonylureas were the first of its kind, if not the first, OHs which were developed in 1942. That was way back. So 1942 to 2024, 82 years of experience with that, and various things have come across. We have gone past the older SEs and we have come to the newer sulfonylureas. So, plenty of experience, the clean evidences from India, like the Curious 2020, the Curious 2021, and even in 2022, plenty of studies with metformin and glimepiride, metformin and glimepiride compared to sitagliptin, glimepiride compared to linagliptin, and also glimepiride compared to sitagliptin and the DPP4s and the EZPs as well. So plenty of experience. Also the 2017, the START trial which involved glimepiride with sitagliptin. So is it the ugly duckling? In that modern era, is it the ugly duckling? Perhaps not. So sulfonylureas, they control glycemic levels. In turn, they control both the macro and microvascular complications. The complications are delayed or prevented, and also they are a good competitor and they are important attributes and remain as oral OADs, especially for the global context of a limited resource. I mean, limited resource means those who are not financially developed, those who do not have deep pockets, and those who actually live in remote areas where hardly other molecules are available. So, coming to the GX studies, sulfonylureas as proper OG every class. So, it has shown good glycemic control and safety profiles associated with with glimepiride. So, the concern is, we often say, when we treat a diabetes initially, whether we covered the entire myriad, whether it is an umbrella therapy, whether is it covering the heart, is it covering the kidney, is it affecting the mortality and morbidity of the patients? It is whether the patient will have good glycemic numbers, but he may die of a stroke or a heart attack. We have to think like that. Now we are thinking, but whether we should not prescribe sulfonylureas? No, it should not be the case. It should not be the case because sulfonylureas also have some evidence. In fact, a good number of evidences regarding these things. So this is the latest shade of green safety study, where glimepiride was associated with reduced cardiovascular mortality in patients with type 2 diabetes. Now, this is a small study, this is not a dedicated CWAT, but there is also some evidence about cardio safety. So, Also, the cardio safety as second line drugs. It has also been shown that glimepiride also reduces inflammation. It also has antioxidative properties. It improves insulin sensitivity and it increases glycogen synthesis and inhibits neoglucogenesis. So this also has a very good coverage. So also there was a comparison with DAPA. Although DAPA will definitely score ahead of sulfonylureas, but let me say, it is a secret of all. We do not expect positive cardiovascular responses from sulfonylureas, but as long as they are cardiovascularly neutral, we will accept that. So we can say that it has got a good coverage in overweight diabetes, in patients with newly diagnosed diabetes, in patients who have comorbid conditions, and also in patients who are elderly and who are not prone to hypoglycemia. I repeat, elderly but not prone to hypoglycemia. So they have also got good data when they are co-used with other agents. There is also a profound or a significant HbA1c reduction with glimepiride. So we have talked about this time and again, the ideal foil, metformin and glimepiride, and how they have given us good results in patients over a long time. The experience is very long with usage of sulfonylureas and metformin. I'll skip this because this MODI and sulfonylureas itself on one-hour topic from my side. I will not skip. I'll just skip that. So, what is the position of glimepiride in the present era? So many guidelines advocating use of modern sulfonylureas, but most importantly, the population, the poor population in India, where the majority of the patients are out of the pocket. They pay out of the pocket to buy medicines. Diabetes is, we say, a lifelong disease. When the patient comes to us, we say, Oshud Sara Jivan, exercise Sara Jivan, power restrictions Sara Jivan. So, the cost of the therapy is also important, and also the availability of the drug. The patient comes to you, then goes back to his own remote village, and after that, if he doesn't get the molecule, get the product, he will stop. He will stop taking the medicines, and he will come to you in a totally deranged condition. So that is also very important. So this was actually the great study which evaluated the CKD outcomes, and we saw that there was also decrease in EGFR, increase in EGFR and decrease in renal progression with sulfonylureas. This is the U policy. Now, diabetic patients we will get in all these three spectra: predominantly catabolic, predominantly anabolic, or maybe eubolic. So sulfonylureas actually sit in the center, the eubolic spectrum. So that is why you can prescribe it across the range of patients. Now, we can say that already I've said about the access or cost. This AAC consensus guidelines, this mention about sulfonylureas when this access or cost factor is taken into consideration. So, still, sulfonylurea, the modern SU stand tall in terms of experience, availability, affordability, effectiveness, proven cardiovascular safe, acceptable, and surpassingly researched. So, we still will use the modern sulfonylureas when in Indian patients who are usually out of the pocket patients, who actually majority of the population lives in remote areas. This still stands tall in terms of as a first or even a second line therapy of type 2 diabetes. So the message from the sponsors: let's take a small step towards making the change. Go Green Planet. Thank you so much.
Arcojit, nice presentation by the way. I have got a small question first time diagnosed diabetic patient, two defined case scenarios. One is a 35-year-old obese gentleman, office goer, incidentally diagnosed as having a fasting blood sugar of 246. And another case scenario, 60-year-old male patient, again incidentally diagnosed as having a similar level of fasting blood sugar. So how does your approach to treat these two patients differ, or does it at all differ?
First of all, 35-year-old, that is somewhat a young diabetic. First thing you have to see is the patient you have said is obese. So we have to choose drugs which actually address this obesity. If the patient has deep pockets, we can go for GLP-1 RA, also combined with metformin, or we can choose SGLT2s if the patient does not have very deep pockets. Along with this, we can also choose glimepiride and metformin because among the SUs, glimepiride has evidence of least weight gain. So if the patient is very poor and if the patient is living in a village, he will definitely get a hold of glycomet GP. He will not get hold of some CWPs and linapeptins. That is number one. Second is the 60-year-old. I have already said if the patient is also coming from a remote area, we can consider giving sulfonylurea and metformin as the first line. Definitely, we will prefer giving DPP-4 and metformin because already we have said that DPP-4 inhibitors are very safe, and I think I will take that word from Swami. He often says you can prescribe DPP-4 inhibitors across over phone also. So it is very safe, but again, availability is an issue, and if the patient is not prone to hypo, you can definitely prescribe metformin and glimepiride. But again, we have to make sure that the patient is given a comprehensive healthcare. The patient is given a comprehensive diabetic, cardio and renal safety, and the patient does not die of a heart attack despite having good dressing numbers.
Thank you.